Okay, a very good afternoon to everyone. Thank you very much for joining the Regional Surgical Advisors Network of the Royal College of Surgeons of Edinburgh's webinar. And today we have the pleasure of having Mr. Barnabas Green, one of our very, very experienced vascular surgeons based in James Cook, Middlesbrough, and he's going to talk to us about below and above knee amputations. Barney is a very, very experienced teacher, he's a very experienced surgeon, and he's also the Deputy Director of the Regional Surgical Advisors Network. And I'm sure we will learn a lot from him, and I'm sure we will then be able to enhance our knowledge and clinical skills during this session. Thank you very much, Barney.
Okay, just getting unmuted. Thanks, Peng, for that. That's very kind of you. Now, we have got about 20 minutes or so to go through amputations. And that's a tall order, but I shall try and keep it to what's relevant to you going forwards. Okay, so the first thing, just to tell you where we're going to go, we will touch very briefly on the indications for major lower limb amputation. What I don't want this to be is a textbook set of, case scenarios, pathogens involved, etc., etc. This is broad outlines of why somebody may require amputation. And then I would like to go and look at what makes a good amputation, kind of the what part of the surgery that we need to keep a very close eye on and for a functional and good outcome. I'm going to take you through some tips on technique itself. And then finally, if we have time, I would like to show you a few pictures of some of my own patients, some of my successes and failures, all of whom have consented to have their imaging used for teaching purposes. If some of you are squeamish, it's advisory, so please, look away at the right time. A quick disclaimer, really, there will always be somebody out there who can say, well, I can do a better job. And did you not think of, reattaching this tendon and that tendon through the bone? There will be different specialties who do amputations. There will be the purely reconstructive orthopedic / plastic surgeons. We, when it comes to amputation, have to appreciate that we are dealing principally with people who have no blood supply. That's why we're doing the amputation. So therefore, I am, I suppose, a destructive surgeon. I can take anything off, I can remove the badness, but we always do that with a reconstructive principle in mind. One key theme that I want you to take away from today and to always advertise is that an amputation should never be delegated to the most junior person on the day to go and have a go, as if it's the end of the road. An amputation done badly is very bad. An amputation done well is very good and gives people their life back. So we always have, although a destructive process, a realistic reconstructive ideology as well. Now, amputations have been done for centuries. In fact, if you go all the way back to circa, somewhere around about the birth of Christ, Aulus Celsus wrote in his text, which has still survived through to this day, tips on how to do an amputation. Let's just look at that. Amputation for gangrene should be through the sound and should be between the sound and disease part, the flesh cut to the bone undercut, leaving tissue adherent to it, overlying tissue sufficiently loosened so as to be brought together, and any skin not brought together to be dressed in lint, and over that a sponge soaked in vinegar to be bandaged on. If you just take away from the talk today his description of how to do an amputation, I'm sure you will survive. Not so sure about soaking it in vinegar, but you can see these were early ideas on how to keep unknown bacteria at bay. So he actually got it pretty much spot on. But the technique back then was fraught with difficulty, rather crude, and had major problems with hemorrhage, sepsis, and of course death. So people didn't survive it that well. You needed an unwilling patient to be held down by willing volunteers. There was no general anesthetic. There might have been some alcohol to numb it. And invariably, you had to do a very quick procedure as a consequence of all of that. Well, things have moved on since then, thankfully. But we are still faced with the same three real causes of why you might need to do an amputation. And loosely, these can be broken under three headings, and they all begin with the word, or the letter D, so quite easy to remember. First of all, the limb may be dead. In the case of gangrene, there is no resurrection of that tissue, so you must remove it. The second D stands for deadly. So if you had nasty spreading gas gangrene and the patient was horribly septic, then a guillotine amputation would be required. That limb is deadly to that person. And from time to time, we would do an amputation when the limb is a dead loss. Now, I wouldn't for a minute suggest that the patient in this last picture here should be offered an amputation. But it's not infrequent that we have patients who have contractures, who develop pressure necrosis between them that get infected. And so you may offer them an amputation as long as the rest of the patient was in a position that would actually prolong their life and make a difference. So deadly, and dead loss are the three indications for performing your amputation. What about in the UK? What is the burden of disease, or why do we do this? Well, this is a chap called Bill, and Bill volunteered to show off his body to the CDC in the States, and they ran a series of tips from former smokers. He's age 40 here. He's already had loss of vision in one eye. He's already had a coronary artery bypass graft. He's had an attempt at a fem-pop bypass graft, and he's had an amputation. And this is all because he has diabetes and he continued to smoke. And we know that there are a number of major causes of peripheral arterial occlusive disease. And in this country, it is the diabetes and it is the arterial disease that fills our burden of disease. The Mirror says 135 victims each week, people with diabetes who have amputations. As we go on to see later, they weren't that far off the mark. So what is the life cycle of a vascular patient? And this is what your general surgical colleagues who don't understand vascular would have you believe. You go from the fem-pop to the fem-flop because the graft occludes to the fem-chop. And we're not really that keen on that caricature of what our work is all about. Progressively distal bypass followed by progressively proximal amputation. And it's that attitude that we have to fight against, to say, no, an amputation isn't something to just be pushed to the end of the list, to be done by somebody who doesn't really care about surgery. An amputation has to be done, and it has to be done well. So looking at this, there was a document recently just published, but started collecting the data a couple of years ago, at how we can get it right first time. And when they come to look at vascular surgery, GIRFT tells us 43,000 procedures each year in England, 450 consultant surgeons. If you want a career where you're doing nearly 1,000 procedures a year, that's 3 a day or so, come and be a vascular surgeon. And out of those 43,000, 8,000 lower limb amputations. So the Sun's data tells us 135 a day, so that's 7,000 something, so they weren't that far wrong. The mortality rate is frightening, 7.5%. That is very significant. And why? Because our patients are frail, they have multiple comorbidities, and that myth of the amputation should just be done whenever by anybody else is propagated, and eventually they get done in the middle of the night and they don't do so well. So how do we get it right first time? How do we do a good amputation? What is it that makes it good? 4 things really. First of all, you must have a good blood supply. If you haven't got a good blood supply, make the supply good if you can. Your decision making should be fundamentally important to you. You need to communicate. Losing a limb is a bereavement, and a patient and their relatives will bereave that limb. They will go through all the stages of bereavement, and you must give them time whenever possible to deal with that. Preoperative counseling. What will my life be like? Will I be able to drive? Can I walk? What will my house look like? All of that sort of information is very important. And when you're making the decision about the amputation, what is in the best interest of the patient? We probably haven't got time to go into full detail of that, but we'll scratch onto this a little bit later on. And what about the surgery? You have to employ the most particular of your skill sets. You have to be meticulous in your hemorrhage control, in your surgical technique. Don't damage anything that will come back and bite you. Choose the correct type of flap and do it at the right time of day. And then when it comes to looking after the patient afterwards, getting it right first time means look after their pain, help them with phantom limb, try and get them psychologically able to be discharged and deal with their home circumstances. So what about a good blood supply? Well, first of all, you must always do that. Now, as a trainee vascular surgeon, you will want to know what their blood supply is like, but you'll be surprised at how many people take a toenail off without assessing a blood supply, and suddenly we've got an above-knee amputation. So that foot that you can see there, we've had a toe removed, presumably in a patient with diabetes who has tibial arterial disease. Now, that had to be revascularized with an angioplasty before you could take that toe off. Otherwise, it's a below-knee amputation or worse. If you can feel a pulse, that's very reassuring. If you've only got an audible Doppler signal, you probably need to go and find out why before you do what you want. And remember, it's a palpable pulse and a Doppler signal. It's not a Doppler pulse. Please remember that going forwards. Impalpable pulses should be investigated, and wherever in doubt, just refer on. Now, this formidable lady is not an arteriopath. She is a child of Chernobyl. But what she's done in life with her amputations is quite remarkable, or rather her limb bud developments that have required prostheses. But in broad strokes, if there is no palpable femoral pulse, the amputation level will be an above knee. But if there is a palpable femoral pulse, then the amputation level could probably be a below knee. So what about decision making? Well, again, we don't have time to go into full detail about this, but it's all about what's in the patient's best interests. And sometimes nibbling away and trying to get away with it, so no femoral pulse, let's try a below knee, and we'll watch that for 3 months if it heals or doesn't heal, and then we'll do an above knee amputation. That might not be quite as good as saying, in your best interest, it's an above knee, even though that's a much bigger job, you'll be out of hospital quicker, rehabilitated quicker, and so on and so forth. Other questions such as, well, if the level is I can't have a below knee and I must have an above knee, is there anything else? So what about the through knee? How does that affect you? And what are the considerations for the person going forwards with that? Good surgery. Well, the principles of surgery probably don't need going over, but keep the infection out of way, get some antibiotics, look after the other organs, for example, ensure urine output is good and cardiac output is good. Make sure they have blood, because anemia and cardiac disease is not good for you post-operatively. I wouldn't recommend using a tourniquet because guess what? There isn't a blood supply. So you don't really need that tourniquet to control hemorrhage. Make sure you take care of hemostasis and so on and so forth. Now, the two little pictures on the right of the screen there are to demonstrate to you that if you operate out of hours, you have got nearly a 3-fold risk of dying. And that's not because of the time of day particularly, it's because of the myth. It's just an amputation, it will wait. And when that patient goes through 3 or 4 days of fasting and then feeding and then fasting and feeding, they get weaker and weaker and they're already behind the curve and then they die. So when we audited this and we shifted our out of hours operating into in hours operating, you can see what that did to our overall mortality rate, which incidentally used to be around about 12% nationally and is now less. Some very quick principles on surgery, and you can look at these again later in your own spare time. But to do a below knee amputation, so here we are looking at the left leg, looking at the medial aspect, you must measure correctly first. They must have enough bone to be able to fit into their prosthesis to get good walking prosthesis. My hand is about 10 or 12 centimeters in length, and so I put my hand on the tibial tuberosity, the top of it, really, or the tibial plateau, I suppose, measure down, and then add on a little bit extra, half a centimeter or so, to get your circumference. Roughly speaking, 1/3 of the circumference down, 1/3 of the circumference along the leg, and then complete it around the back. Now, if you make your flap like that on your gastrocnemius muscle, you've got square edges, which I don't think close well. So curve them off nicely, just like that. Then you start to divide your skin, you get down to the fascia, and you must cut square down, straight down, don't undermine, straight down, take out the fascia and expose the muscles. The flap is made on the gastrocnemius muscle, so you're going to lose the rest. Don't be tempted to keep that in. It will make it too bulky and they won't get a good stump in the end of the day. Control the vessels, transfix them individually. Allegedly, there's a risk of getting an AV fistula, but remember, these have got blocked arteries. It's unlikely, but the textbooks would say that. And divide your fibula about 4 centimeters, so 1.5 inches more proximal than your beveled tibial osteotomy. You remove that muscle, you turn your flap back up, and there you have your below knee amputation. As for the above knee amputation, pretty similar. Measure, try and leave it long if you can, because the longer you have it, the more lever they have, the more control they'll have getting out of bed. Measure your circumference, find your halfway point on the medial and the lateral sides, then measure out your quarters of the circumference, and that gives you the flap. Now, if you look at that and that looks too tight, then make the flap skin a little bit longer. Fundamentally, I would always say the bone, the osteotomy, has to be way back behind the apex of your flap. Otherwise, the flap will be too tight and it will end in disaster. Separate the skin, go through the fascia, take the muscle off nice and square, divide the bone, put in a nerve catheter if you believe that's helpful to them, and then bring the fascial layers back together again and close the skin. So that's what I would suggest. When it comes to post-operative management, this is really important as well. Perioperative really. The preoperative counseling is really important to tell them what to expect. If you have the luxury of time, get your occupational therapist to talk about home, what changes they might need to have in terms of wheelchair access and so on and so forth. Post-operatively immediately is going to be good, robust analgesia. There was a phase of giving people a preoperative epidural because that allegedly helped them with phantom limb pain post-operatively. And that's good if you've got the time and no sepsis. But quite often when someone comes in really sick, we haven't got time to do that. So we use sciatic nerve catheters and femoral nerve blocks to help. Of course, all of the analgesic tablets are there to help with your phantom limb pain, your gabapentin, pregabalin, amitriptyline. I had one patient who had such intractable phantom limb pain that we failed with medical management, but he was effectively cured with a mirror, just like in this picture here, where his brain was tricked into believing the leg was still there. And there's a lot more research going on in that field at the moment. Physiotherapy, you don't really need me to tell you how important that is, but prevent the contracture, build up the strength. And no matter what you say to a patient, and no matter how obvious you think it is that they've had an amputation, they will all fall. So advise them, educate them, look after them as best as you can, and pick up the pieces when they fall onto that stump and split it open. So those are my tips. I just want to show you a couple of my patients where I've had to do an amputation, and you can tell me what you think as we go along. So this patient has diabetes, a neuropathy, ischemic heart disease, and was a war veteran. This is a neuropathic diabetic heel ulcer, and you can see we're right down to the bone. The decision making here is, well, why don't we just treat that ulcer locally? Well, you could do that. However, once the heel is gone, then there is not much of a functioning foot. So you can't do a forefoot amputation. You can't do a heel amputation really. But what can you do to give this person their life back? First of all, look at their blood supply. They've got good blood supply based on their angiogram. And here we can see that because he's a war veteran, he's already lost the other leg. So we would say, let's do everything that we can to preserve this limb because it's a precious limb. And if we're going to be forced into an amputation, what should we do? And in this case, a bologna amputation worked very well, and he retained his independence, really. This is a patient who presented with a big, nasty necrotic area over his knee. He was cachectic, he hadn't looked after himself, and you can see the end of his femur sticking out there. Well, that's not going to be a bologna amputation, is it? But you must still do due diligence, look at the blood supply. It's a little bit hard to see here, but his iliac arteries, his distal aorta is heavily calcified. In spite of that, the above knee amputation healed quite well, and he went home. And he had a bit more nutrition on him when he went home. This is a gentleman who uses intravenous drugs, who presented with a bleeding pseudoaneurysm. So he's got a Rutherford Morrison incision to get to the iliac, and then the femoral artery was ligated. Most of these patients, by some miracle, end up keeping their leg, but in this case, he required an amputation. And I thought, well, let's do a through knee amputation. I might have been too hasty because 4 or 5 days down the line, the necrosis, or rather the tide went out on what his blood supply really was like. And here you can see the necrosis of his through knee amputation flap, and that had to be converted to an above knee amputation. Do you remember, it's all about communication, shared decision-making. This gentleman has diabetes and arterial disease. The hallux has already been removed. The GP phoned through and said, could you look at this chap? This is a picture of his foot. I looked at that picture and I said to the GP, send him in immediately. Please do put my dinner in the oven, because the GP happened to be my wife. I need to see him now. That looks innocuous, but that's what happened when I took him to theatre. That was how much debridement you had to do to get all the pus out of his foot, and that does not look like a salvageable foot. So when we woke him up, I said, what do you want to do? We'll have a bologna amputation. You'll be out of hospital in a few days / weeks, and you'll rehabilitate on a limb. And he said, I'd like to keep my leg. So we negotiated. And over the next few weeks, he lost a few more toes. And then back in my outpatient clinic, he came back like this. But this was 12 months later, during which time he followed the instructions. You must not walk. He didn't walk, and he did really well. So it doesn't all have to be doom and gloom, but you must always think about the patient's best interest in all of your decision-making. And from time to time, you get surprised. So just to close, really, if you take one thing home, I want you to remember an amputation is not an end-of-the-road procedure. It's not the final act before death. It is the final act before life for a lot of people. And you must remember that, and you must broadcast that to your general surgical colleagues who are all vying for space in the emergency theatre list. If you do it badly, that is not good. If you do it well, it will give somebody their life back. So always do your best for that. Communicate the expectations very clearly at the start. Make sure that you have full buy-in from the patient, and you understand that they must be realistic as well. And they say, I want to climb, the mountains again. That might not be realistic, but getting back to a decent degree of life is fundamentally important and doable. Above all else, if you can get it right first time, it will always end well for the patient. So an amputation is a life-giving operation. Never forget that, and never be underestimating quite what the human body can do at the end of the day. That's it. Over to you, Peng.
That's great, Barney. Thank you very much for a very, very clear lecture on the amputation. This is a very important topic, as invariably through our career as surgical trainees, we will encounter patients needing amputations. We may also encounter patients post-amputation. Just to start off with, Barney, one of the questions from the participants is, how long post-amputations can patient try on prosthesis?
Yeah, that's a really good question. I think when you're a hospital practitioner, you've got to remember that there are procedures that get followed. So first of all, you'll do your amputation. I would expect, on average, a patient to be in hospital for about a week to 10 days, because during that time, unless we've known about it before we've done it, we'll have to start all the social arrangements, the discharge planning, the occupational therapy, the home assessment, the wheelchair, and so on and so forth. In the early phases, they'll also need to build up their strength. So they'll have to get arm strength. They'll learn how to transfer from a bed to chair safely. They'll have to learn how to use their wheelchair safely as well, because a number of them that go over the back of their wheelchair because they think wheelies are cool, that all happens. So that takes a lot of time. The physiotherapists will take that patient's detail and they'll take them to the rehabilitation center very early on, and they will start inspecting that wound, that stump, or the residuum, as is the politically correct phrase. And when the wound starts to knit together, the first thing to do is to start to mold it and to shape it. And you do these with a series of socks, sort of close-fitting socks, and you're trying to get the edema out of it, and you're trying to get good consolidation of the tissues underneath. Then nothing is lost, because during this time they will also continue the upper body training to get the strength in the arms, so on the parallel bars, learning to balance again, particularly important in above knee amputees. And then as that residuum starts to knit together, they will go through learning how to walk with a prosthesis that's not a socket prosthesis, but sort of just something that makes their legs equal length. And when we're sure that the stump has reached its final volume, bearing in mind that the volume changes on a day-by-day basis, but the average volume, it will get measured up for a prosthesis, that will be fabricated, and then over the next few weeks, that can be trialed out. That process usually takes about 3 months. So I wouldn't expect somebody to be walking independently before that. Certainly not when they're our age patient, in their 60s, 70s, and 80s.
That's very well answered, Barney. Now, the next question has two parts to it, and it's probably something that's very relevant to us. So the first part to the question is, do below-knee amputation patients need TED stocking post-op? Okay, so I think it's something that's very close to our heart. Barney will probably answer that very well. And secondly, oral anticoagulation, is oral anticoagulant sufficient post-op?
Yeah, okay, all right, let's answer your first question. You have to remember what patient cohort we look after. We principally look after the arteriopathic patient. So although we do somewhere between 50 and 70 amputations a year, Actually, the reflection during COVID is we might have been doing more than that because people have stayed at home and come in, at the end stage of their disease so that we couldn't get to them earlier. That's anecdotal, I should say. But somewhere between 50 and 70 a year, and they're all arteriopaths. So if the person presents to me and I find that they have TED stockings on in my patient cohort, we're usually in trouble because they've got arterial disease and they shouldn't have TED stockings. So we find actually that simple subcutaneous low molecular weight heparin, the prophylaxis for DVT, is satisfactory. For those patients who are trauma patients, now that is a different cohort. And so they get managed in a different arm. They've got invariably normal pulses. Again, it comes back to clinical examination. So have I ever put a TED stocking on a patient who's had an amputation? Yes, I have. On the vascular ward? Yes, I have. But why? Because I examined them and they had palpable pulses and no evidence of arterial disease. So they can have a TED stocking. If you want to try and confuse your colleagues, your nursing staff, and people who might not know different and just go, well, they have TEDs and they don't have TEDs, then try and make a non-blanket rule. Try and make individualized plans because then everyone gets really confused. So actually we find it's easier just to say vascular paths, no TED stockings, and that's it. We also find, just whilst we're on this subject, that we probably lose one limb per year unnecessarily because a patient on another ward whose pulses have not been assessed have been fitted with TED stockings, and they've gone off for their anterior resection or whatever it is, and a couple of days later complained of leg pain, and it's too late. So TED stockings also harm patients. The second question about oral anticoagulation, again, you have to ask the question why somebody might be on oral anticoagulation. If they need it for other medical reasons, for example, atrial fibrillation, then yes, that's absolutely fine. If it's to manage arterial disease, it's not necessary. Best medical therapy at current practice is clopidogrel. So an antiplatelet agent would suffice.
Thank you very much, Barney. Occasionally, we may see patients who are very, very ill, very septic. What sort of amputation would you advocate in those circumstances?
Yeah, that's also a good question. If somebody is really sick from gas gangrene, then you want to get them into theatre, have that surgery quickly and get them out. The baloney amputation would probably take a senior trainee or an early consultant somewhere between an hour to an hour and a half. And above knee amputation might take someone about an hour. So in the middle of the night, let's not fiddle around with those. Let's just do something called a guillotine amputation. So take them in, take your knife, circumferential round, saw through the bone, and just put a dressing on it. Control the bleeding and then put a dressing on it. Come back another day. Remove the sepsis and then move on. So guillotine amputations are good to do. Now, what I have done before, under local anesthetic even, somebody with gas in the foot, take them to theatre, light sedation, bit of local anesthetic, and just take the foot off through the joint. So all you're dividing is tendons. There's no bone sawing or anything like that. That would add extra distress and pain. So a quick guillotine amputation to remove the sepsis is important. Get the patient well, then reassess and bring them back for their definitive procedure. So I have no problem with doing a guillotine amputation at all.
That's great, Barney. Now, this is probably a difficult question. When you have to consider amputation versus a life-saving limb therapy, what would you advise patient in the low socioeconomic and low resource and bad post-amputation rehab facilities?
An amputation versus what, sorry?
Long-saving limb therapy. I suspect the participant asking the question is, would you consider amputation, or would you consider a prolonged lower limb revascularization in a low socioeconomic and low resource area?
Yeah, that is a good question. By nature, we are limb-saving surgeons. We will always try and save a limb. And I think, in the UK, we will be audited against our limb revascularization versus amputation, and within our amputation group, below knee versus above knee amputation. So that is a matter of public record because we submit that data to the National Vascular Registry. Wherever possible, I would try and save a limb. But if that is not possible due to resource, and if in this country, I think I would be slow to do an amputation primarily if there was a revascularization option. can understand overseas. I mean, I grew up in a country where there was very limited resource, and actually a good amputation that had a restorative function was also equally acceptable. I'm not sure there's a right or a wrong answer. I think, discussion, explaining what is at stake in each arm of treatment is really, really important. It's probably not a very satisfactory answer, I'm afraid, because we're so geared towards having all the resources around us. But actually, even here, there are times, not infrequently, where we would say, we could try this femdistal bypass graft. We've already tried once, we could try again. But you're going to have 3 months of pain in hospital. The wound might not actually heal. And at the end of that time, we may still go on doing an amputation. If you are prepared to remove the middle part of that, and you accept and you understand, let's just get on and do the amputation. And for some people, that's really liberating to have somebody help them say, actually, all I want is get back to life as quickly as possible. I don't want to have prolonged agony, even if I get to keep my foot. So yes, all and above, I think, is the answer, Peng. Oh, he's muted.
Yeah, that's great, Barney. Thank you. Now, what would you do if, let's say, you've been called up to do a trauma and the patient has been trapped in a vehicle and you have to consider doing amputation? These are the things that as surgical registrars in the past, we had to sometimes be on standby and we had to go out to help. Any tips for the participants when you have to go out and have to consider doing amputation up in the field?
Yeah, so thankfully this is extremely rare. And the reason why that's extremely rare is that paramedics and fire brigade are suitably equipped to deal with this. I have a good friend who's a fire brigade chief, and he presented me with a study where they were comparing a paramedic amputation versus a fireman amputation using one of their pneumatic cutters. I mean, it sounds quite gruesome. What's at stake? If somebody is bleeding to death, trapped in a vehicle, and the only way to extricate them is to remove that limb, then you're going to have to do that at the roadside. How are you going to do that without them expiring? Well, they're going to need pain control. They're going to need someone to control an airway. So ketamine, rapid sequence induction, perhaps. It's going to be a team effort. And how you take that limb off really is going to depend on what is presented to you and how much is trapped. So if it's a distal extremity, guillotine it as far down as you can and let somebody who does reconstructive amputations deal with that at a later date. I would be really upset for you if you were called to the roadside to do that. And thankfully, that's very rare. And even as a vascular surgeon, I have never been called to the roadside to have to do an amputation.
I think that's great, Barney. That's pretty much the time that we have for this session. And thank you very much, everyone, for all your questions. This has been a very engaging session. The next talk will be next Tuesday on the 21st of July, and that will be on the management of hand injury, and this will be delivered by Daniel Saleh from the Northeast. So thank you very much, everyone, for your participation.